بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. The topics we have to be discussed regarding the women psychiatry or women mental health, which is a branch of psychiatry that deal with the women mental health because of gender differences in the mental disorders, as the recent research has identified disparities between women and men in regard to risk prevalence, presentation, course, and the treatment of mental disorder. Regarding the learning objective, we have to define the premenstrual dysphoric disorder and to compare and contrast the clinical symptoms of premenstrual syndrome and a premenstrual dysphoric disorder. And we have to recognize the primary risk factor for developing puerperal mental disorder and to differentiate among the clinical symptoms of postpartum blues, postpartum depression, and postpartum psychosis. We have to articulate the rationale for each of the following modes of the treatment for the mood disorders, medication management, non-pharmacological treatment strategies, and ECT. And we have to also to formulate an educational guide for clients with a puerperal mental disorder. Women all over the world are the biggest consumers of health care. They live longer than men and have more illness and disability than men. They receive doctor's surgery more than men, fill more prescriptions, have more surgical procedures, and occupy about 60 to 70% of hospital bed. This أن Tinker's Words Bank. هاي المقولة كلش مشهورة وهاي according to the recent research studies الwomen أكثر شيء هي بالهوسبيتال ستاي والهوسبيتال بيد تاخذ تقريبا 60 إلى 70%، وأكثر سيرجري ممكن تكون مستهلكة وأكثر تستهلك الهيلث كير سيرفيسز in addition to the mental health services. So women are most likely than men to suffer from depression. Lifetime risk of depression for women about 10 to 25% versus 5 to 20% for men. Between 10 to 15% of women who give birth will develop postpartum depression. Women develop many anxiety disorder more than men. Whatever the types of anxiety disorder, for example, generalized anxiety disorder, specific phobia, OCD, obsessive compulsive disorder, or other types. Women are 2 to 3 times more likely to suffer from panic disorder. Slightly more women than men develop Alzheimer's disease, as we know, and we are familiar that there is segregation of cases of Alzheimer's disease within a women population. More than 75% of migraine sufferers are women. Premenstrual dysphoric disorder. This is the first topics to be discussed regarding the women psychiatry. By definition, premenstrual dysphoric disorder is a somato-psychic illness triggered by changing level of sex steroid that accompany an ovulatory menstrual cycle. السيفير ديجري مال البريمنسترول تنشن سيندروم نسميه premenstrual dysphoric disorder، اللي هو خلاله يصير عند الwomen socio-occupational deterioration أو affection of daily functioning. When reaching a severe degree so-called نسميه premenstrual dysphoric disorder. But the milder degree نسميه premenstrual tension syndrome, as up to 85% of women can be suffered from premenstrual tension syndrome, اللي هو يتألف من constellation signs and symptoms just like mood lability, nervousness, eagerness to eat high calorie food just like chocolate or cacao or any type of eating, and also suffer from breast tenderness, headache, might be lability of mood. These signs and symptoms are of mild to moderate degree, so what is called premenstrual tension syndrome. But if severe degree and affecting the woman functioning, so-called premenstrual dysphoric disorder, as it occurs about 1 week before onset of menses and characterized by irritability, emotional lability, headache, anxiety, depression. Somatic symptoms include edema, just like leg edema, weight gain, breast pain and tenderness, syncope, which by definition syncope, momentary loss of consciousness, paresthesia, has tingling sensation of peripheral extremities. The disturbance markedly interfere with works or school or with the usual activities and relationship with the others. Approximately 5% of women have the disorder. But I have a research in the previous year. I did a research regarding the premenstrual dysphoric disorder, and I found the prevalence among Iraqi population about 8.1. Premenstrual syndrome is distinguished from premenstrual dysphoric disorder by the severity and the number of symptoms, as well as to degree to which function is impaired. The treatment, really the premenstrual tension syndromes, no need specific treatment, but changing the lifestyle important. But in premenstrual dysphoric disorder, we have to treat the patient as the treatment outline is lifestyle change. Symptomatic management include analgesic for pain and sedatives for anxiety, insomnia. Some patient responds to short courses of SSRI, just like fluoxetine or sertraline, citalopram, escitalopram, paroxetine, or sometimes can be used B6 or magnesium in some research. Fluid retention is relieved with diuretics, can be used diuretics to relieve fluid retention as the presentation for just like leg edema. Another important topics was the premenstrual perinatal mood disorder. Antenatal mood disorder, the myth that pregnancy is protective against psychiatric disorder. This is just a myth, not truth. Severe psychiatric episodes are less frequent during a pregnancy. Research has shown women experience anxiety and depression during pregnancy at the same rate as postpartum, 10 to 15%. إذن هي نفس السيفيريتي regarding those in postpartum period, نفس السيفيريتي and the same prevalence. Obstetric and neonatal complication of depression. شنو المتوقع الكومبليكيشن اللي هي ممكن تصير بسبب الدبرشن؟ لذلك early detection and diagnosis and early intervention was very very important for women suffered from depression, as there is risk of fetal growth retardation, preeclampsia, premature labor, placental abortion, postpartum disorder. There is a spectrum of postpartum mood. Postpartum symptom severity from postpartum psychosis, which is the severe degree, postpartum depression occur in about 10 to 15% of women. Postpartum blue, the risk of occurrence about 50 to 85% and known. This the spectrum of postpartum mood. Postpartum blues, or what's called maternity blue, about 80 to 85% of women suffer from postpartum blue within the first 2 weeks after delivery. Mood lability and tearfulness and anxiety and sleep disturbance, minimal or no impairments of functioning, no affect the functioning of the woman in the puerperium. Time limited, so really not need a treatment, just education and support to the woman. Postpartum depression, postnatal depression, tends to start within a month of delivery. 1 in 7 mothers are affected. The symptoms are unremarkable, with the negative thoughts tend to focus on the woman's perceived failings as a mother or on her baby well-being. Physical exhaustion exacerbates matters. Postnatal depression may put the baby at short-term risk, and if any treated, may lead to problem with bonding and child development. So there might be a risk of child isolation or even sometimes autism spectrum disorder risk. Most cases, puerperal psychosis. Puerperal psychosis actually is a rare condition which might occur in about 1 to 2 per 1,000 birth. The disorder can be severe. Perplexity and delirium-like state are characteristic. Perplexity I mean الحيرة، يعني متحير، صعوبة باتخاذ القرار، وdelirium اللي هي acute confusion state أو هذيان. Onset is usually in the second postnatal week. second يعني بالنفاس، الأسبوع الثاني من النفاس يكون. Risk factors include a past or family history of puerperal psychosis, a diagnosis of bipolar disorder, especially mania, and being a prime gravida, إذا first pregnancy عندهم. The baby is a potential risk because of mother's delusions or because she is so preoccupied by her symptoms that the baby is neglected. Occur risk of infanticide might reaching about 4% of cases of postpartum psychosis or puerperal psychosis. Just like there is a delusion that the woman see her child as a monster. So the assessment should specifically address these issues, or if there is a risk of infanticide. The management, admission to the hospital, is usually necessary. Treatment with antipsychotic and antidepressant, and with a low threshold for ECT, which was indicated in case of severe cases if there is a risk of suicide or infanticide, which often produces a dramatic response in a case of ECT. Full recovery is usually, but there is a 25% relapse rate after the next delivery. يعني ممكن 25% تنعاد الحالة اللي هي puerperal psychosis ممكن تصير بالnext pregnancy, and 50% lifetime risk يعني مو during الباربوريوم ممكن end their life. In summary, postpartum psychiatric illness is common. Any treated illness has significant impact on child development and well-being. مثل ما ذكرنا ممكن premature baby, placental abortion, or abruptio placentae, pre-eclampsia ممكن يكون عندهم. Effective non-pharmacologic and pharmacological treatment can be used, just like psychotherapy and medication, antidepressant أو antipsychotic ممكن نستخدمها in puerperal psychosis. Early treatment is associated with a better prognosis. Early treatment, early diagnosis, early intervention is very important for gain a dramatic response. And thank you a lot for your listening, and goodbye.